Imagine a patient came to you with fever, chills, shortness of breath and productive cough. So when you did physical examination, you observed some things. Then after, for diagnosing purpose, we did chest x-ray. In the chest x-ray, you can see this type of white opacities. So we have to understand that is pneumonia or how much severe is it, how we have to treat that thing. So in this video we are discussing everything step by step in simple way. Okay, so what are the things I am covering in this video means definition of pneumonia, pathophysiology, clinical features and how to do physical examination and investigation, management, the treatments of antibiotics, how we have to give and how much duration, the frequency, what type of antibiotics we have to use. Everything we are going to discuss in this video. Watch till end because this topic is very important and very high yield topic. So it will help for your competitive exams. So as usual, without time waste, let's start our video. Myself, I'm Dr. Anand, final year medical student. So let's start. So first of all, clinical scenario. If you are seeing this clinical scenario, you can see here a 52 years old male with chronic smoker and it presents with fever, productive cough with rust colored sputum and pleuritic chest pain and breathlessness for 3 days. On examination, the respiratory rate will be like 28 breaths per minute, the saturation 90% of room air. So the bronchial breath sounds in right lower lung we can see while doing percussion dullness, like, and in chest x-ray it shows right lower lobe consolidation. If you are seeing this x-ray, here you can see here the right lower lobe is total filled with consolidation. The costophrenic angle is we can't see, and next one is like blunt costophrenic angle we are seeing here. Next one here the bronchogram you can see and little white opacities, that thing we call consolidation. Okay, so why this patient got this problem means the risk factor we can see here chronic smoker and the clinical features like fever, productive cough, rust colored sputum. Rust colored sputum means something is causing that sputum. Okay, some organism. Next one, pleuritic chest pain because of that something is going on in that lung field, in lung parenchyma. That's why that patient getting pain. We will discuss everything in pathophysiology. Next one, you can see breathlessness, shortness of breath. Okay, so now what is pneumonia? Pneumonia is like acute infection of lung parenchyma that usually occurs in defined lobar patterns through may also present more diffusely. If you are seeing this image here this is the lung lower part. In this lung lower part, if you are seeing in alveoli, something is happened. What happened in alveoli means the alveoli become inflamed. Next, it filled with some exudates. Just see this image. In this image, this is lung. In this lung, if you are zooming that alveoli, you can see the air space. Okay, that air space will help to do gas exchange. But here what happening, whenever the patient filled with pus or inflammation, then what will happen, the alveoli filled with totally with pus. Whenever that fluid, that airway sacs filled with fluid or pus, then it will contains like more amount of bacteria and blood cells. Because of the pus, that gas exchange will reduce, then the patient will get hypoxia and shortness of breath and the body will react like systematic manifestation because of the patient will get fever and systemic problems. Okay, so that's why this is very important. The pneumonia is very most common condition. Wherever you are going in medical settings, you can see 100% you can see this pneumonia conditions. That pneumonia also divided into two different parts, that is community acquired pneumonia and hospital acquired pneumonia, also known as nosocomial pneumonia. So community acquired pneumonia, it's not related to hospital settings. So mostly because of the community acquired pneumonia, that most common organism is strep pneumonia. Okay, next one, hospital acquired pneumonia. After admitting in hospital, within 48 to 72 hours, if patient getting this type of shortness of breath, fever, chills and productive cough, then we have to suspect that is hospital acquired pneumonia. Okay, so this is the difference between this CAP and HAP. So now you can see here pathophysiology. Before knowing pathophysiology, we have like step by step what's going on inside our lung. Easily we can find out. First of all, some organisms, the infectious agents entering to our lung field and alveoli. How? Because of inhalation or because of aspiration. In alcoholic, aspiration pneumonia is most common, because when after getting like too much alcohol consumption, the patient will get aspiration pneumonia. Because of that thing, in lung field, the alveoli will filled with pus and everything. So if you are seeing this image, you can see here, first of all, the infectious agent, the microorganisms will enter into the lungs. Next one, after entering in alveoli, the bacteria microorganisms will become colonized. That means it will divide. It will divide and it will become multiples. Next one, whenever any microorganisms entered into your alveoli, your body will activate the alveoli. In alveoli, we can see some macrophages. That is, the macrophages will help for defense. Then it will activate some cytokines. It will release some cytokines like interleukin 1 and tumor necrotic factor alpha. Because of whenever that macrophage is releasing interleukin 1, because of inflammation, the patient we can see fever. Next one, we can see some neutrophil migration, then alveolar exudate formation. Because of that thing, the pus will form there. Okay, whenever that pus will form, the total alveoli, that bronchioles will filled with pus. So that condition, if you are doing X-ray, in that X-ray you can see some consolidation or white opacities. So that's why we can call that is pneumonia. Okay, pneumonia means some infection happen in lung parenchyma and it's causing breathing difficulty. Or you can think like inflammation or consolidation is known as pneumonia. Okay, so whenever the consolidation happen, because of that thing, in alveoli we can't see gas exchange. Because of that reducing gas exchange, that condition we call oxygen diffusion will reduce. Then that condition we call hypoxia, or in blood, if that oxygen saturation will reduce, it means then we call hypoxemia. So this is the pathophysiology of pneumonia. Now we have some classification. How we can classify that pneumonia means we have total 3 different types of pneumonia. One is lobar pneumonia, bronchopneumonia, next one interstitial. Okay, so in classification we can see like lobar pneumonia means it's like intra-alveolar exudates with consolidates. So in lobar it will affect only one lobar, and it intra-alveolar exudates with consolidates. It may involve entire lung or be confined to the lobe. So it may be like lobe, it will fill with lobe, or it will, you can see total it's filled with total lung. Second one, bronchopneumonia. In this bronchopneumonia, it will, that pneumonia, that consolidation you can see in bronchioles also, like acute inflammatory infiltrates from bronchioles into adjacent alveoli, and a patchy distribution, and it involves greater than 1 equal to 1 lobe. So that's why we call that is bronchopneumonia. Third one, interstitial. This interstitial, you can see more amount of diffuse patchy inflammation. If you are doing X-ray, you can see interstitial infiltrates. Okay, it localizes to interstitial areas of alveolar walls and it distributes involving greater than equal to 1 lobe. It is generally less severe than lobar or bronchopneumonia. Okay, why it's easy? Because whenever patient getting pneumonia, here we have 2 different types of pneumonia. One is typical pneumonia, another one atypical pneumonia. In typical pneumonia, you can see it will affect lobar. It's like mostly we can call lobar pneumonia, that is typical pneumonia. We have some organisms, that is strep pneumonia, Haemophilus influenza, Klebsiella or Moraxella catarrhalis. And next one, atypical. It's related to total interstitial pneumonia, mostly mostly bacteria like fungal, viral. This type of things will cause that is atypical pneumonia. In this atypical pneumonia, that is interstitial pneumonia, we can see like mycoplasma pneumonia, chlamydia, chlamydophilia pneumonia, legionella pneumonia, and viruses like influenza, RSV, SARS, COVID-19. So these are the typical and atypical pneumonia. So if you're seeing here, we have some causes and risk factors. In causes, I already mentioned about typical pneumonia, that is strep pneumonia and Haemophilus influenza. In atypical, we can see like interstitial pneumonia, that is mycoplasma, chlamydia, and legionella. In viral, we can see influenza, RSV, COVID-19. And in aspiration, we can see anaerobes. For example, most common we can see aspiration pneumonia in alcoholics. And hospital acquired settings, we can see Klebsiella, Pseudomonas, MRSA. Whenever patient coming with pneumonia, we have to think about the strep pneumonia, that is the most common. In severe cases, we have to think about if any patient have resistance with this, we will discuss in management. If any patient getting resistance, then we have to think about MRSA or Klebsiella or Pseudomonas. Okay, so what are the main risk factors means, like elder people and patient with COPD and age like less than 5 or greater than 65 years old, and smokers, alcoholics, diabetes, chronic kidney disease and COPD, and immunosuppression and stroke. And next one, decreasing consciousness. If any patient coming with pneumonia, in old age people we can see mostly confusion. In young age people we can see like some shortness of breath and this type of like fever, chills, productive cough, and decreased breath sounds. Okay, and the lung is not getting it's not increasing properly. That's the asymmetrical expansion. This type of things we can see in normal teenage and adult people. But in old people mostly we can see confusion. Okay, so this is the risk factors. Next one, clinical features. Before knowing clinical features, based on the typical pneumonia and atypical pneumonia, we have clinical features. Okay, in typical pneumonia, like shortness of breath and this type of things will be like sudden onset. That patient will get like sudden onset. And next one, productive sputum, cough. We can see if you are doing X-ray, in that X-ray you can see lobar consolidation. That is typical pneumonia. In atypical pneumonia, you can see like gradual onset. The cough will be like dry cough, and if you are doing X-ray, you can see diffuse infiltrates and extra pulmonary features like myalgia. Every muscle the patient will get pain, and some diarrhea and confusion. So these are the things, atypical pneumonia clinical features. So if any patient coming with pneumonia, before knowing that is typical or atypical, we have to understand the signs and symptoms, how the patient will present, the clinical manifestation. So the signs is, we can say like tachypnea, fever, crackles, bronchial breath sounds, and we can see, while doing physical examination in dullness, we can see percussion, while doing percussion we can see dullness and the reduced saturation. So next one, in symptoms, fever and cough, it must be like productive in typical, dry cough in atypical pneumonia. Next one, dyspnea, that is difficulty in breathing, shortness of breath. Next one, chest pain, because the lung is not getting properly expanding, so that lung will get tired and it will cause pain. So that condition we call pleuritic chest pain. And patient will get fatigue because of hypoxemia and reduced consciousness and confusion. So these are the clinical features. So while doing physical examination, inspection, percussion, palpitation and auscultation. So in inspection, you can see that lungs are expanding properly or not. Next one, we can check with our same to same. You can see this image. In that image, that person is holding from back, and the patient, the doctor, the physician will tell that patient to take deep, like inhale. So whenever they are taking deep breath, that time that we are checking the lung expansion. If the lung is not getting to like proper expansion, then we have to think about that is something is obstructing. So that thing we call, then we have to think about pneumonia. Okay, so in percussion we can see dullness over affected lobe And while doing tactile phragmatis means we have to hold and we have to tell that we have to keep our palm or ulnar area in our lung fields. That time we have to tell that patient to tell like some number or some word. Then when they are telling, we have to listen, we have to feel that vibrations. That vibration feeling we call that is tactile phragmatis. That in pneumonia, the tactile phragmatis will increase because of consolidation. Because of that consolidation, the pitch, the sound will become like more. That's why we can see that is tactile phragmatis will increase. In pleural effusion, the tactile phragmatis will decrease because of fluid. Okay. So in auscultation we can see like decreased or bronchial breath sounds. Next one we can see some crackles, because whenever that fluid filled in that alveoli, so the sound that space is very like narrow and it will become less. So that's why we can see some crackles and real sound. In some cases we can listen wheezing also. And we have one test that is egophony, that is we have to keep your stethoscope on lung field and we have to tell that patient to tell E. E means elephant. Then whenever you are listening that sound, the patient, that sound we can see while coming out, while producing speech, that word, that time that sound will come like A. That means that the pitch will change. So the egophony, the test will be positive in pneumonia. Okay. So this is the physical examination. So next one we can see investigation. In investigation, first we have to do imaging, that is X-ray. In that X-ray we can see like consolidation and air bronchogram. You can see here, this is X-ray. In this X-ray you can see here some consolidation happening in right upper lobe. Okay. So if any patient not getting like we are getting problem with diagnosing with chest X-ray, then we can do CT chest if unclear. Okay. So in investigation, imaging X-ray is the best option and gold standard. Next one, for investigation we have to do some test like that basic lab test, that is we have to do CBC. In that CBC, the increased white blood cells and CRP, the CRP will, C-reactive protein will increase like greater than 5 milligram per liter, and procalcitonin. This procalcitonin test is very important. Why? Because if it increased means we have to suspect that is bacterial. So bacterial pneumonia. If it decreased means we have to think about that is some atypical pneumonia because of that fungi or mycoplasma or pneumonia or something like viral. Okay. So that's why another thing we have to check always saturation. If like normal means greater than 94 means no problem. If less than 92 means we have to think about like pneumonia things. Next one, microbiology. In microbiology test we have to do sputum test like gram stain and gram culture. Or we have to do some blood culture. In blood culture, when we have to do in severe cases, if patient getting like confusion, we have one criteria. In that criteria, like we call CURB-65 criteria, we will discuss later. In that criteria, if patient getting like after using medication, after using antibiotics, still that patient not getting any recovery, in severe cases we have to do blood culture. So these are the step by step of investigation: imaging, then after some lab test, then after sputum culture, gram stain and culture, then after blood culture. So these are the things we have to do investigation. Next one, for diagnosing, we are using right now in GPHC, in Georgetown Public Hospital, we are using CURB-65. This is like one type of criteria to find out severity of pneumonia. So this CURB-65 score means, C means confusion. If patient have confusion, we have to give 1 point. How we find out that confusion means the patient must be like conscious, alert and orient. If they are not in these three things means we have to think about confusion, then we have to give 1 point. Second one, urea. If you are doing blood test, in that urea, the greater than 7 millimole per liter, the respiratory rate will be like greater than equal to 30 breaths per minute, and blood pressure will be like less than 90 systolic, and the age greater than equal to 65. So based on these 5 things we can give 5 points. If like 0, how we can interpret it means 0 to 1 point means then we have to treat that patient like outpatient. Just we have to give some antibiotic and macrolides like azithromycin, these things for 7 to 10 days. Then we have to send that patient. If that patient like that criteria will like more than 2, then we have to admit that patient and we have to treat in hospital. If that criteria like greater than equal to 3 to 5, then we have to send that patient to ICU for ventilation support and for getting recovery. Okay, so this is the CURB-65 diagnostic criteria. Okay, next one, how we have to treat this patient. If any patient coming with pneumonia, we have to go step by step. First of all, we have to know the cause. Some other causes also can cause pulmonary edema. And second one, we have to think about symptomatic management, means like primary survey. We have to check A, B, C, D, E, after like airway, breathing, circulation, and the drugs. We have to give like blood, like for collecting blood samples and treating with the fluids, and for collecting samples and fluids and starting antibiotics. Okay, so these are the like step by step approach. So in pharmacological management, we can use, you can see here some antibiotics. Based on that antibiotics we have to treat, but before that we have to check vitals, and every like we have, if that patient like hospitalized means we have to admit that patient. We have to check vitals every 4 hours. If patient like diabetic, we have to check RBS, and we have to check saturation, and we have to give some fluids, and we have to give chest physiotherapy. Okay, so these are the things we have to do in management. If patient like symptomatic management, if patient getting pain, we have to give some morphine or analgesics and paracetamol. Okay, so for antipyretics, for patient getting any fever, we have to treat that fever and everything. Then like stomach protectives like omeprazole or rabiprazole, these are the things we have to give. So next, antibiotics. In this antibiotics, if patient like first regimen is, if any patient getting like mild, like moderate and severe, based on this CURB-65 criteria we have to use. In mild community acquired pneumonia, we can use amoxicillin, like class of drug is penicillin, 500 mg PO every 8 hours we have to do for 5 to 7 days. Next one, macrolide. Why we are giving macrolide? We can use azithromycin or doxycycline 100 mg. Azithromycin is 500 mg for covering the atypical organisms, okay, like viral or fungal things. So azithromycin we can give macrolides 500 mg PO or OD 5 days for 5 days for atypical coverage. If azithromycin is not available, if the patient is contraindicated, then we have to go with doxycycline. Next one, ceftriaxone. If patient have like moderate community acquired pneumonia, then we can give ceftriaxone. The ceftriaxone like third generation of cephalosporin, we can give 1 to 2 grams intravenous like OD 7 to 10 days for moderate community acquired pneumonia. Next one, if patient getting like after giving this antibiotics, patient not getting any recovery, then you have to think about Pseudomonas. In Pseudomonas, we can treat with peptides, piperacillin, tazobactam. This is a broad spectrum antibiotic. The dosage is 4.5 grams intravenous every 6 hours for 7 to 14 days. We can treat this thing with, if patient getting like severe or hospital acquired pneumonia or in ICU cases. Next one, levofloxacin. If the patient is allergic with penicillin, then we can go with levofloxacin like fluoroquinolones class. Some 50 mg we can give intravenous or post oral. Okay, next one, OD, and duration will be like 5 to 7 days. This is like alternative medication. Next one, now based on severity we can treat that patient mild, moderate and severe. For mild pneumonia, for outpatient we can treat with amoxicillin and or azithromycin, or we can give combination drug also. Next one, moderate. In moderate pneumonia, like for hospitalized patient, we can treat with ceftriaxone and azithromycin. In severe cases, I already mentioned dosage, that's why I am not mentioning another time. In ceftriaxone like 1.1 to 2 grams, azithromycin 500 mg. Okay, in severe cases, if patient like ICU patient, then we have to treat with piperacillin, tazobactam or azithromycin or vancomycin 15 to 20 mg per kg. Okay, we can treat. If you are suspecting MRSA, then we can add vancomycin. If you are suspecting Pseudomonas, we can give piperacillin tazobactam. Okay, so this is the things. Now we have some side effects, but thing is, whenever patient coming with any pneumonia cases, we have some regimens of giving oxygen supplementation. First, oxygen mask supplementation. After that, if it's not getting, the saturation is not increasing, we have to check every 5 minutes and 10 minutes. If the saturation is not increasing, then we have to go with high flow of oxygen nasal cannula. After using that thing, we have to go with, still that patient saturation is not same to same like that before, means then we have to use dual therapy, means oxygen mask and nasal cannula. After that, we can go with non-invasive like ventilation like BiPAP or CPAP. After this thing also, if patient not getting any oxygen means, then we have to go with intubation. Okay, before giving intubation, we have to do ABG. In that ABG, we have to check that respiratory acidosis, then we have to treat that thing also. Okay, so this is the things. Now we have some side effects and contraindications. In side effects and contraindications, like macrolides, for macrolides, the side effect is QT prolongation, and we can see some fluoroquinolones like levofloxacin. For that thing, tendon rupture is the side effect, and aminoglycosides, that is it can cause nephrotoxicity. For MRSA, if you are using vancomycin, it can cause red man syndrome. And fluoroquinolones we have to avoid in pregnancy, because it can cause that it will cause problem to the baby. So that's why. So in complications, what are the complications we can get with pneumonia means, that is pleural effusion, emphysema, lung abscess, sepsis, acute respiratory distress syndrome, another one respiratory failure. So these are the complications. How we can follow up the patient means, the clinical improvement within 48 to 72 hours. We have to repeat that chest X-ray after 6 weeks if patient likes elder people or smokers like greater than 65 years old age, or patient have any immunosuppression problems, or patient have like smoker, then we have to repeat that chest X-ray. Next one, we have to monitor saturation and fever and the WBC count. So these are the things. So in this video, we discussed about pneumonia from basic to advanced levels, like definition and some causes, what are the causes and risk factors, clinical features, sign and symptoms, and based on the typical pneumonias, we have some different sign and symptoms, and atypical pneumonia have different sign and symptoms, and investigation, how we can interpret the chest X-ray, okay, and management, and what are the antibiotics we have to use, the complications and side effects of drugs, and how we have to do follow-up and monitoring. Everything we discussed, and see CURB-65 criteria, everything we discussed in this video. So if you didn't subscribe my channel, like, share and subscribe. So we will meet in our next video. Every time we will discuss like different topics from like with PPT and with presentations. Sometimes we will do case scenario also. Okay, so we will meet in our next video. Till the time, take care. Bye bye.